Good morning, good evening, good afternoon, wherever you are. Welcome to LASEM's Q&A session, where we bring our industry-leading researchers and allow you to pick their brains and get their insights through our online format. It's great to have you here for the first time if this is your first time, or back if you've been to our previous sessions with either Jill, Ebony or Tanya. We're really excited because here at LASEM we feel like we've got an embarrassment of riches of researchers that are not only researchers but still see patients in clinical practice. Tonight, and I'll get her to unmute her microphone and turn on her video, but tonight we are lucky enough to have Dr. Ebony Rio, who's an NHMRC Early Career Fellow. And her fellowship's looking to understand how neuroscience can improve or the management of chronic knee pain. She's also still practicing, sorry, we're just having, there we go, there's your video. She's also still a practicing physiotherapist with the Victorian Institute of Sport and has previously worked at the Australian Institute of Sport, the Australian Ballet Company, and been to a number of Commonwealth and Olympic Games. And above all that, she's good peoples. So thanks, Ebs, for jumping on with us tonight.
Oh, thank you so much for the invitation. I'm completely chuffed to be invited.
Brilliant. So we've just got a bit of housekeeping of how tonight is going to work. So what we're going to do is I'm going to ask Ebs some questions just to start with for the first 5 minutes or so. And then you guys, our participants, have the opportunity to ask your questions and get it answered by Ebony. So how best to do that is in the webinar function, you'll see at the bottom there is a Q&A button. And if you can put your questions into the Q&A function, that allows us to see it. It also allows all the other attendees to see it. So if someone asks a question that you really want to see answered, there is also the ability to upvote it. So if the higher it is in the list of questions, the more likely I am to see it and the more likely I am to ask it. I can also suggest that have your microphone ready, because one of the things that we'll try and do is we'll actually try and come directly to you so that you can ask your question. So have your microphones ready and we'll be good to go from there. So Ebs, a couple of warm-up questions just to get us in the mood for tonight. So it's no secret that you've married well. Your wonderful husband, Joe. And it's lucky because Joe's a fantastic cook and I can attest to this. So what's Joe's go-to dish? What do you reckon's the dish that's is the most impressive that you like?
Oh, he does a pretty good pasta from scratch and he's cooking that tonight, I think because I'm not home, just to rub it in. So he makes his own pasta and it's pretty ridiculous.
Do we know what sauce is going with it tonight?
It's a anchovy, broccolini and Parmesan cheese sauce.
Oh, that
Nothing
sounds like
out of a jar happening at my house, unless I'm home.
Well, that goes on to my next question. So you've got two wonderful little boys as well. What do they think of your cooking?
So Cooper, my now 7-year-old, did say to me, they get very stressed if my husband's out about what they'll have for dinner. And I offered to cook and no, please don't cook, mummy. And I was like, oh, that's not nice. Oh, but you do a really good wheat bix, mum, which is what I got from Coops. So yeah.
But it's what you do, like the castle in the castle. It's what you've done with it. It's the milk, it's the right amount of wheat bix, it's the combination. So I'm sure that's why he's so impressed with the wheat bix.
I appreciate your support, thank you.
And the other thing with one of the side benefits of coronavirus is there seems to be a lot of parents learning new skills because they've had to teach their children certain things.
Oh, man.
So is there any Indonesian that you want to share with us? Because I know that Cooper's been practicing and there's little cards around the place. So how is your Indonesian at the moment?
I think I can still say Selamat pagi, and that's about all that I picked up in the entire period of homeschooling. So I'm really sorry, Indonesian teacher. I let the team down.
Well, at least the Cooper's got an excuse in case the report card comes back a certain way.
Exactly.
Brilliant. All right. So get your questions and answers ready. We'll be going to you in a sec. But Ebs, I sort of wanted to start because the whole session that we wanted to discuss today is where is research useful and how does it impact your practice? And as I said at the front, you still do see patients and treat patients, not only with tendinopathy, but lots of other complex conditions. So I sort of want to start with a scenario of you've gone through the research, you've found this research paper, and you've decided, well, this is an intervention that I want to implement in my practice. And then the patient in front of you doesn't respond as expected. So you're a fantastic thinking clinician. You go back to the paper trying to understand maybe why you didn't get the result you thought you were going to get. What are the sort of aspects or sections of the paper that you're going to help try and explain why you may or may not have got the response you thought you were going to get?
Yeah, cool question. Okay, so the first thing you have to do, I think, is break it down into 3 chunks. So you have to accept that you need to read more than the abstract, and we've all been guilty of that. But the 3 chunks that I would focus on is the who, the what, and the when. So the who is the participant, and examples might include, how similar is it to the person in front of you in terms of activity level or gender or, sport condition. Remembering that a condition can affect people that have a goal of just getting on and off the floor as well as playing elite sport. The what is the intervention? How closely have you been able to replicate that intervention? There's exercise and then there's exercise. And also in research, we look at these little chunks. We might look at someone for 4 weeks, whereas when someone comes to see me, they have a functional goal that might take months. And the last part of the chunk would be the when. So are we talking an in-season intervention? Is it rehabilitation? It's really important to put it in the context of how that research was conducted and whether or not it's appropriate to the person in front of you, because a lot of what we see can't be applied in season, for example.
Great. So it's one of those things, especially when we're talking about the who, we do research on groups of people and then we end up applying these interventions to one single individual. So I know you were recently part of the consensus statement in tendinopathy about what are sort of the minimum requirements of the sort of things that we should be talking about or reporting about our participants. Do you want to go through about what some of those things are and maybe why they're important?
Sure. So I don't know about you guys, but if I read one more paper that says more research is needed, I don't know what I'll do. I won't swear. So it's really important that we're able to get the most bang for our buck out of research and replicate research and implement it in clinical practice. And the only way we can do that is if we have a ridiculously thorough understanding of who was included. Now, I feel really passionately about differential diagnoses if it changes your treatment direction. But the only way we can talk about differential diagnoses is actually response to these interventions. So the first step is describing who's in the study. So a good example might be, I might be really interested in where these patients were recruited from. Because if you are recruiting patients for a qualitative study about tendinopathy and asking their views on exercise, it's going to be really different if you've got people on a surgical waiting list versus, people that are already engaged in exercise. Are you paying the participants to be part of the study? Are they recruited as part of an injection study? All of these things are really important because they speak to the non-specific treatment effects in research and clinical practice.
That's great. Thanks for that. Now, guys, get ready with your questions. We're going to be coming to you soon so Ebs can answer any questions you may have. Now, one of the things is, I suppose, in physiotherapy or musculoskeletal practice is we're often talking about implementing complex interventions. So not your sort of simple intervention where we can look at a drug versus a placebo or a medication versus placebo. We're talking about sort of almost systems approaches where we're sort of implementing multiple different exercise programs. So these are by nature difficult to implement and translate into clinical practice. What do you see as some of the barriers to actually trying to implement these complex interventions, or the barriers for research to try and help inform clinical practice?
Absolutely. Well, the first thing is, as clinicians, we actually need to be evidence-based, but never recipe-driven. And the reason for that is the person in front of you differs in so many ways to the group of people that are included in research. You might have someone that has completely different goals and aspirations. They might have a different past history of injury. So their start point might be different and their goals may be different. So the critical thing is we need to draw on the research to say, well, how do we progress this person towards their goals? But in research, the easiest way to compare something is to approach it like a drug trial, where we look at one single component for quite a short period of time and try and standardize everything else. And we've done this kind of research. So to give you an example, we looked at an in-season trial comparing isometrics and isotonics for 4 weeks. Now, you'd never do that clinically. You'd never do one solitary intervention and expect that that is going to be the panacea of rehabilitating that person. So you've got to look at the research question that they're asking. And we were asking a really specific question around in-season pain management. But in terms of that's not recovering someone to their functional goal. So a barrier for me, Sean, would be that people are really complex. In clinical practice, we can adjust our interventions on a really individualized basis. But in research, it's very much trying to apply the same intervention and then look at some sort of effect from that. And that's very difficult to do, especially in pain.
Sorry, just having a bit of technical difficulties there. Now, I might take this question from Heather Foster, who asked, and this might sort of go to speak to your who question, or your trying to understand who's in your population. How would you go about treating, or how do you treat distal Achilles tendon presentation from mid-portion Achilles tendon presentation?
Yeah, really lovely question. And the critical thing, and this is what I was saying before about differential diagnoses, it only matters when it changes your treatment direction or it changes your advice. And so tendinopathy provides such a fantastic example. So if we take our distal tendon, our insertional tendinopathy, and we compare that to our mid portion, then it really gets back to meeting the person at their story, as David Butler would say. So someone with insertional Achilles tendinopathy are really provoked by compressive loads. So they'll report having pain with bare feet, walking around in bare feet. They might have failed the eccentric Alfredson program off the step because of the compressive component, whereas your mid-portion Achilles tendinopathy are really not bothered by walking around in bare feet. So it matters because we give different advice, and it matters because we give different start points of load. And if I can throw in there even like a peritendon presentation. So again, the biology in this biopsychosocial model is critical, because someone with a peritendinitis are provoked by movement loads. So if you don't pick that up and you give that person calf raises, well, then they're likely to be non-adherent. And that's a really big issue, because we often reflect non-adherence just back on our patients. But I'm really intrigued, if someone doesn't do their exercises, is it what I've given them? Have I made them worse? Why haven't they done them?
It's a great perspective. I just really wanted to pick up on your sort of comment about eccentrics in Achilles tendinopathy, because I think that it's a really good example of sort of what you're sort of talking about in terms of the who, actually what the intervention is, and then how it's sort of altered the narrative around eccentrics. So just wonder if you could sort of almost share a bit of a history about eccentrics, and then how we've almost got to the point of where eccentrics sit in your clinical management, or how you incorporate it in your understanding.
Sure. So I think any single exercise intervention would be unlikely to recover everyone to their potential and their goals. So I think we have to realistically say, how does it fit within the spectrum and our clinical practice? So there's going to be no one exercise that rules them all. So if we consider something like eccentrics, and I'll defer to Miles in a second, but there's evidence in quite specific cohorts. So the original research was conducted in middle-aged men who were recreational runners awaiting surgery, with mid-portion Achilles tendinopathy. And then, as we often do, we apply that quite broadly. And what we started to find is we didn't have the same positive effects in people with a higher BMI. So that's why BMI is critical to report in studies. We didn't have the same effects in women. Well, women and people with a high BMI is a big proportion of the people that I see. And the environment one, the wear that I spoke about right at the start, we didn't see positive effects in season. So that's why applying the intervention and working out, right person, right dose, right time, all of the principles of medicine really apply to implementing our interventions.
And even
sorry, I was going to say, do you want to ask Miles? Because he's done that fantastic work on the eccentrics.
I will, yeah. I was just going to sort of say, in terms of, just to go back to your point, in terms of a lot of interventions have been called the Alfredson exercise and the eccentric program, yet there's been such variation in terms of how it's actually been applied, and what was originally the Alfredson protocol isn't necessarily what the Alfredson protocol is reported in current studies. So I think that is a great chance to bring in Miles. So if you can unmute and bring your video up, Miles. Miles is a current PhD candidate at Notre Dame. I'll just get your video up. Is a current PhD student in Notre Dame in Western Australia, and looking at researching the Achilles tendons. So first of all, welcome, Miles.
Thanks. Can you hear me properly?
Perfect. Brilliant. Now, just to follow on from Ebs, she was mentioning about sort of eccentric exercise and how there might be different responses. You recently had a systematic review that looked at the different rates of response following different interventions. Did you want to sort of share that a little bit with us?
Yeah, so we did two different systematic reviews. The first one that we did compared the traditional Alfredson protocol. So for those of you that aren't aware, that's 3 sets of 15 straight leg and 3 sets of 15 bent knee eccentric contractions off a step twice a day. So if you do the maths on that, that's 180 eccentric contractions a day. And we compared that with all the studies that had been done, and there was only a few, to a lower dose program. So it's sort of the same exercises, but every second day, or they just did it as tolerated. And what we were able to show is that there was no differences between. There was a slight statistical difference in favour of the smaller exercise groups, but nothing that you consider clinically important. So because there wasn't really huge differences between the protocol, what we wanted to do was, from a clinician's point of view, get some guidance on how we can expect our patients to respond when we implement these in a clinical setting. So we pulled together every study that had done exercise, and there was about 40. There was quite a lot of studies. And then within those, some of them had multiple arms. And we're able to see that by completing an exercise intervention, quite clearly within the first 4 weeks, you'd be seeing some improvements within your patients. And that by 12 weeks, you're expecting about 21 points of change on a VISA-RA, which is sort of what we'd consider something that's very clinically significant. So I think as a clinician, what you can expect to see with these exercise interventions, and based on the protocols that have been done, it doesn't seem to matter which one you choose, is that you'll get some immediate responses within the first few weeks, but you've really got to wait for 12 weeks before you're getting sort of large responses, which I think would resonate with most clinicians. When you're doing exercise interventions, you don't just give it once and expect the major problem to be solved. It actually takes quite a while to build capacity within the tissues and change someone's experiences, as well as build in other loads.
Fantastic. It's sort of really important for managing patients' expectations, isn't it? Because they're always asked, how long is it going to take? Fantastic. So, Ebbs, I've got a question from Hamish Ashton, which I'll ask him to unmute now, which I think is a really fantastic question and really points to one of the frustrations I think we all have with trying to translate research into clinical practice. So, Hamish.
Hi, guys. Thanks for having me on. So, yeah, my question is basically with your tendons and things like that, we seem to have a reasonably good idea what we're talking about. But if we then look at things like backs and shoulders, that we don't tend to use a diagnosis. So my question sort of comes from that, when we don't have a sort of real true diagnosis in backs, shoulders, other things like that, how accurate is this sort of research really when you're grouping a whole lot of possible different things together?
Oh, that's such a cracking question. And Hamish, I would go so far as to say that we're actually not that good at discriminating people into even something like tendon research. So if you look at the criteria or our clinical tests for most conditions, it will provoke lots of different clinical presentations. So that's a cracking question, because where I go back to is that sort of first principles of listening to the patient of their specific provocative loads. So if we're going to take something like, let's take the patellar tendon, for example. There are so many ways that the patellar tendon and patellofemoral pain are similar. They're probably more similar in terms of their provocation than they are different. So the devil's in the detail. So someone with patellar tendinopathy, we talk about really localized pain with really high tendon load. So what's high patellar tendon load? Maximal jumping, really fast change of direction, lunging at a tennis net. Now, those things might aggravate your patellofemoral joint as well, but what doesn't aggravate a tendon then, by definition, if your definition is rate of loading, what doesn't provoke a tendon is something static and something slow. So something like cycling or running can provoke your patellofemoral joints. So finding out from your patients, but also finding out in research, the differences in who is included or who you're applying it to is really, really important. And I would say that even conditions like non-specific low back pain, they're going away from that again and actually really trying to be much more individualised about the patient and the participant features to try and improve this. Because if we have a really heterogeneous group of people included, which is what happens commonly in studies, then we end up at the end with some people are better, some people are worse, some people are no different. And clinically, that's actually really unhelpful. We really don't know what to do with that. Does that answer your question, Hamish?
Yep, generally on that. And that's why I sort of have trouble with, you get a technique and research says it doesn't work, so everyone gets on the bandwagon, we should drop this technique because it's not shown to work. But, the groups you see is hugely diverse.
Oh, correct. And you know what? Every patient you see is an N of one experiment. And I would hazard a guess that a lot of clinicians that are using the evidence are actually far better at discriminating who they apply that to than just throwing things in or throwing things out based on a paper, because I think clinicians really start to gather that the features, the subtle features. So again, just sorry everyone to talk tendon, but I can't help it a little bit. If you take something like inclusion criteria for a study and it's pain with palpation or imaging change, then a lot of conditions hurt to hop, so you could feasibly, or a lot of conditions hurt where you just squeeze the Achilles tendon. It could be peritendon or sural nerve. If you include all of those people, then again you get that heterogeneity. But I think clinically that discrimination is much better than what we do in research, and that's an issue because I think there is this. I think a lot of people don't have a foot in both camps, so I think that's a challenge.
Mute. I'll unmute myself. Sorry. Brilliant. Thanks so much, for Hamish, for that question. Now, this might seem like a planted question, but it definitely isn't. But we'll get another one of a question from Danilo. Danilo, you had a great question. Would you mind asking Ebony that one?
Yep. Hi, Abs. I know you have worked before with Lorimer Moseley. Like in terms of keeping the patients engaged with their rehabilitation, how important do you think is the language the clinician uses to communicate with them?
Yeah, I'd argue it's almost the most important. That's a brilliant question. So again, if we bring it back to something we all know and love, tendons. So if we consider our language about the pathology, if the patient is using a term like tendonitis, then their underlying understanding of the biology is that this is inflammatory. And if they think that this is inflammatory, then they are not on board with your exercise program or the process. If you ask anyone, what they think they need to do for, an inflamed tendon, I would guarantee they would go for passive interventions like rest ice anti-inflammatories. So just ensuring even that you correct their language and reframe it and really make sure they understand why that's important. I don't let anyone get away with tendonitis, not the patient, not the coach, not, the lady at Priceline. Some of you guys have heard that story where I argued with someone in Priceline. That's for another day. But it's so important because of that buy-in and that understanding. At the end of the day, I am unashamedly about health promoting physical activity, and I think exercise is so safe and it's so important that we find ways to engage people with exercise. And when we're cautioning people against different exercises, that makes me really uncomfortable. We should be working out how we can encourage people to exercise. What's their start point? How do we use language that promotes their self-efficacy and really, puts them in the driver's seat of their journey?
Brilliant, Ebs. You've talked a couple of times about sort of non-specific treatment effects. And I think from a research perspective, we generally sort of say it in a sort of negative tone in terms of we can't account for non-specific treatment effects and all the rest of it. But the really interesting part is it also provides an opportunity for clinicians to do a couple of simple things really well to help get an improvement for their patients. So do you want to go through a couple of bit of your understanding around pain, non-specific treatment effects, and where there's some opportunities, some simple opportunities for clinicians to get some easy wins?
So one of the things that I'd like to do is acknowledge the amazing work of Lorimer Moseley and David Butler in really improving my understanding of pain. So I'm going to explain how I explain it to a patient. So we now know that pain is more than just information from the body. We used to think that pain was, from the body we'd get these pain signals that would go up to our brain and then we would feel pain. We very much thought that it was a bodily driven and there might be some modulation happening at a brain and spinal cord level, but that was very much secondary to that drive. And what we now know is that those inputs from the body are part of the story, but only part of the story. And these great examples of that, we can see that people have overcome, incredible feats in really crazy circumstances when there's been huge tissue damage. So it's important to explain to people that difference between pain is a feeling, because as a clinician, that gives us critical ways to intervene. So if you think of your pain like a pie chart, and there's great work in Body and Mind showing this better than I can say it, but I'll draw a little pie, a little piece of the pie, and I'll say, this is the information from your back. And then what we also have here is we have some information from what you can see and what you can hear and your memories, and all of these things contribute to your experience. And it's like smelling fresh bread. So that's from Explain Pain Supercharged. You'll get information, but you'll also see the bakery and you put it together as that feeling. Okay, that's your pain neurotag. So the reason why that's important is clinically we can influence some of the other little pieces of pie, and that becomes really important when people have quite persistent pain. And it can also mean that our language can have an even bigger effect in terms of those non-specific treatment effects. So do you want me to explain the non-specific and specific stuff, Sean?
If you can do it briefly, yeah, that'd be great.
Okay, I'll try and be brief. So a specific treatment effect is, something that you think your intervention is directly affecting, and non-specific are all of the, contextual factors. So it might be something like my expectations. I might say to you, you're going to feel amazing after this. This has been shown to be really effective, and it's going to help your pain, as opposed to, ooh, it's my first day on the job. I hope I get this right. Can you see how that can really reframe people's understanding and expectations, anxiety, and all of those things which can feed the pain experience? It's even in research where, the script or the way things are delivered to people is important, as is, blinding, so that we can trust the results a little bit more.
It's really great perspectives, because I think we sort of patients are coming to clinicians looking for some certainty that they're going to get an improvement, or they're going to have that the clinician knows what's the best treatment and that I'm going to get this outcome, and all those things about the non-specific treatment effect in terms of meeting them at their story and explaining where there actually is uncertainty is so important for patients. We're getting very into the pain sort of stuff, which is, awesome. I know one of the things that you really love, and as you can sort of probably remember from the sign that I made you at the start of your PhD, pain is not where I sort of live, but I think it's another great opportunity to bring in Miles to talk about. So Miles, part of your PhD is looking at condition pain modulation. Now, CPM for short. You still have to explain it to me every time, and why CPM is of importance to the clinicians. So I was hoping you could do that for our audience.
Yeah, so as Ebony just said, pain is a feeling, and within the body there's things that will ramp up your pain and things that will sort of calm it down a little bit. And one of the crazy things that happen is when you get this nociceptive input, so when you get this input of pain from the peripheral tissue, in a normal healthy person, you'll get this descending inhibition effect. So the brain and the spinal cord actually causes this systemic reduction in sensitivity. So you become less sensitive to things. Now, one of the things that occurs in people that have long-standing pain, so typically chronic low back pain, knee arthritis, is they lose this capacity for descending inhibition. So when they experience a painful stimulus, they're not getting this global decrease in sensitivity that a normal healthy control would otherwise have. And the way we assess this descending inhibition is a technique called the condition pain modulation effect, or CPM for short.
Brilliant. So one of those things in terms of we're looking for this altered CPM or a change in CPM. One of the things, though, is we sort of find changes in CPM and we sort of say this condition's evidence of certain aspects of altered pain responses. What are the sort of things, though, in those sorts of studies that we need to be aware of? Because it's from some of the conversations that you and I have had, CPM seems to be affected by an incredible amount of things that are difficult to control for.
Yeah, so that's spot on. And this really links back into what Ebony was talking about earlier with the sample and when they describe who's in the study. Because if you look at the CPM effect, it's influenced by a huge amount of things. Chronic low back pain, knee arthritis, patellofemoral pain, tension, headache, fibromyalgia, all of these things can influence CPM and essentially diminish it. So if you're studying, the patella tendon and looking at the CPM effect in the patella tendon, but you've included people that have knee arthritis and lower back pain, you're going to find that they don't have a CPM effect. And you could actually draw the false conclusion that patella tendon pain results in a reduction in the CPM effect, whereas it's most likely because they have low back pain and knee arthritis. So the key in this is to actually make sure that the studies have either excluded any other form of comorbidity, which is really challenging to do because it means that out of the large sample of people that will present, you end up culling huge volumes. Or the other thing is to at least control for them in statistical modelling. So at least account for the fact that they have knee arthritis, lower back pain, and then do some form of analysis. So if you're reading a study and they haven't done that, I'd be dubious as to the conclusions that's being made.
Keep forgetting to unmute my microphone. It's sort of like it's my first time ever on Zoom. Now, we were going to go to Nicole Bear, and sorry if I've promoted the wrong Nicole, but Nicole Bear, one of her questions was, and it's a really fantastic one, Ebbs, is how do you manage the patient referred from a sports physician who recommended injections such as PRP or corticosteroid injection before, and trying to get them to buy in to commence rehab? So how do you sell the research beyond an advice from a sports physician?
Yeah, that is just a cracking question, and one that I answer with maybe 17 patients a week. Not specifically in relation to, often in relation to injections. So there's a couple of different strategies that I use, and so I'm really happy to share them. And something that I learned from Jill Cook years ago, I would use with almost every patient, regardless of whether or not it's tendinopathy. So Jill explains the relationship between load and capacity, and it's not the only thing going on for people, but it's a really nice way of meeting them at their story. So what you can say to someone is, your capacity only ever just exceeds the loads you put on your tissues. So that's a, move it or lose it kind of prospect. So then what you do is you engage them with what they've done. So, and actually I had a patient today that this is her exact story. So I had Achilles pain, and so I went to the GP and I was told to have 2 weeks off. So I said, okay, dropped your load. What do you think happened to your capacity? And they said, oh, it dropped. And then what did you do? Well, I went back to running. Okay, can you see now that that's a relative overload? Even though you've previously run that distance in the past, it's now an overload for your new capacity. But you had pain, so what did you do? You had another couple of weeks off. Then your capacity dropped. Then you saw a physio that gave you balance exercises and told you not to run for 3 months. No calf work for Achilles tendinopathy. Capacity and load coming down. So what you can start to get them to understand is their story. So something like PRP, am I changing your load or capacity? No. And so it's a really nice way of getting them to appreciate the only thing that will change their capacity. And the second strategy that I often use is, again, meeting them at their story about their specific deficits. So they might have substantial muscle wastage, they might have really poor function, they can't hop, what is it about their presentation? And then actually say to them, okay, what will a PRP change? What will it change? It won't address your strength. It won't address some of the changes we now know happen at a brain and spinal cord level. So we cannot be surprised that it's not a magic bullet. So I'll find a couple of different strategies, but there's some that I use.
Fantastic. And sorry, Nicole, you are there. I just didn't see you in my panel. So did you have any
Yes.
follow-up questions for Ebony on that?
Actually, yeah, I do. Thanks, Ev. That was awesome, and I also used that analogy. But it was actually about beliefs that I was wondering how you can influence that when I'm not sure how many are not physios here, but we're in that constant battle in sports medicine at the moment with the sports physician's toolkit and our toolkit, and when they are referred to us from a sports physician whose toolkit includes PRP and CSI, how do we negotiate that entity?
Excellent. So the other research that I draw on is the fantastic research from Sean. So the donut on the hole is an absolute game changer in terms of genuinely using the research to reassure people, not just saying, don't worry about your imaging. Lots of people have changes in their tendon. For someone that's really fearful, that often doesn't go a long way to allay their fears. So what you can do is say, guess what? There's this great research. You know how you've got that great big fat tendon? How amazing is your body? It's adapted, it's load tolerant. You've got this fantastic big fat lovely tendon that's ready to take load. Now what we have to do is get it used to the load and deal with the muscle and the kinetic chain. We'll do some fun stuff for the brain and it'll all come along for the ride. So I try and use the evidence where I can. The other thing is I'm quite reflective. I think if patients are going off for interventions, what could we be doing better as some of our professions that offer exercise? You know, people that see the sports physician has often seen a number of physiotherapists. So I think if we were better, and that's why I'm careful about being judgmental, because I think often these doctors are put in positions asking, you know, can you do something? I've failed exercise. And so it's difficult for them to re-refer to a physio, even if, you know, the physio they usually use is much more evidence-based. Great question, Nicole.
Yeah, it's certainly create a lot of discussion in terms of, do we need to explain their condition more, or do we need to have better understanding of actually what the trajectory for patient outcomes are, or are we just up against it where exercise requires the patient to actually get in there and do it, and all of these different concepts around self-efficacy and other questions. So we might pick up on that thought, and we'll go to Fatima, who has a question about exercise adherence, and it's probably going to be our last one from the attendees. I know it's sort of how quick time runs through, but Fatima, you had a question about adherence. Do you want to ask Ebony that question?
Yes, thank you. Thank you. Just very quick. You just kind of discuss why the intervention like this, the intervention in a research base is not working for our patients in a clinical ward. My question is, what's your strategy to improve the patient's adherence? Because in the research environment, like you kind of standardizing the exercise, you're getting the patients like doing their exercise under your supervision or in like weekly or monthly monitoring. It's different from the clinical perspective, while you're seeing the patient maybe once a month, like if they are in chronic.
That's such an excellent question. So you're exactly right. Research is often this quite artificial environment where people might be, you know, receiving an incentive to be part of it. They might be getting free treatment. You know, someone's calling them each week because, you know, researchers are desperate to have a full data set, and that's often quite different to clinic. So I think really ensuring from the start that you set up expectations around the goals and the shared goals, and how realistically the time frame to get there. So for something like tendinopathy, I might look at them and say, okay, if we've got substantial strength deficits, it's going to take this many weeks or months, and then we need to retrain your spring, and really setting it up from the start so that they have a realistic expectation from the beginning, and taking the time to answer any questions that they might have. So adherence is a fantastic point around research and the difference in clinical practice. Thank you for your question.
It's so many things we've already covered and spoken about in terms of explaining these contexts and language and all that sort of stuff really does have an impact on things we don't even think about sometimes. So Ebs, last question. I know this is something that you're really quite passionate about, and one of the questions that we've got from our attendees is, a lot of the sports medicine research currently is conducted on male athletes. And I know this is an area that you're passionate about. So one of the attendees asked is, where do you think is the best starting point to, one, improve the research to help aid our management of elite female athletes, but even just not elite athletes, the recreational female athlete as well? Where do you think is the best starting point?
Oh, gee, that's a fantastic question. So is that Nicole's question?
No, it was someone anonymous.
Okay, thank you, Anonymous. It's something that I feel very strongly about. So we have a huge issue in sports medicine at the moment and sports physiotherapy. We really fall through the funding gaps at a national level, and I understand it, these huge health priorities in terms of disease. The challenge that we now have with things like COVID is that some of our industry partnerships might even be even less likely to offer, you know, some of the funding. So what do we do then in terms of providing an evidence base and really, you know, driving our profession forward. And I think I would encourage clinicians and I would encourage researchers to be much more thoughtful about how we can integrate research into clinical practice. You know, I understand being a busy clinician, but I wonder if some of the way we do things going forward might be really quite different, because the challenges, the injuries, the barriers, you know, things are different across sports, let alone, you know, for women. And we are a very under-researched, underfunded group, and that's not likely to change in the near future. I wish I had a more positive answer, but we're going to have to be creative.
It's really going to take concerted effort from not only us as academics, but also universities and also clinicians to sort of saying that this is a area we need to invest in and investigate, because certainly we know all the benefits of physical activity. Anything we can do to keep people, particularly women, physically active has to be a good thing.
And hopefully even, you know, athletes, you know, actually engaging them, you know, why would you want to be part of, you know, giving data? Well, because hopefully we can design a research intervention to reduce your risk of injury that then we can roll out, you know, to the community and keep little girls in sport and little boys in sport, just keep people physically active. Attrition from physical activity because of injury that then leads to, you know, comorbidities and stuff is actually, it's a genuine problem and it's really sad. It's something that I think we all feel strongly about.
I think we can sort of see it as a call to arms rather than something that's actually depressing. So, Ebs, we're probably going to leave it there just because we've run out of time. Firstly, thanks so much for your input, as well as Miles. Great to have your input all the way from over Perth. Brilliant. So again, big thank you to Ebony and Miles, and I'm sure everyone online is giving them a virtual clap as well. Round of applause. Thank you so much for jumping on and all of your questions. There is still a lot of questions that we would have loved to have answered, but maybe make sure you're checking our Twitter account, because we do make sure that we get answer questions in a short 10-minute video, which we'll probably be posting on our Twitter account next Tuesday. So thanks for your questions. Thanks for your attendance. Once you finish the webinar, you will be taken to a short survey. If you haven't filled it in previously, it would be great to get your feedback. We are always really keen to know what you liked and what you didn't like and how we can improve, because at the end of the day, this is something that we see is a service that we can help clinicians, especially in a time where professional development is limited. So again, big thank you to all our presenters. Big thank you to Matt Wordnam in the background who helps run these sessions, and a big thank you to all of you for attending. Have a great night, day, wherever you are.
Thank you, Sean. Thank you.
Bye.